Welcome to our webinar titled Cardiac Complications with Bone Marrow Transplant. Thank you for joining us. My name is Lee Clark, Director of Patient Services, and I'll be moderating the presentation today. As we get started, I'd like to recognize the generous support of our corporate sponsors and the generous support of our patients, families, and caregivers for supporting the webinar today. Due to the high volume of teleconferences on the internet, it is possible you may lose your connection during the program. If you are unable to view the webinar online, you can call in to hear the audio portion of the program using the call-in number in your reminder email. Today's program will be archived to our website within 2 to 3 business days. You will be notified by email when it is live and ready for viewing. Immediately following the presentation, there will be a question and answer session. Please feel free to submit your questions at any time during the presentation. To submit a question or comment, open the Q&A window in the lower part of your screen. Type your question in the small text box window, and when you have finished typing, just hit enter. We'll do our best to get to everyone's questions today. When asking questions, I do ask that you do 2 things to help me manage the incoming question. First, submit your entire question all at the same time. Second, please do not share private health information in your question. Our speaker cannot answer any specific questions related to your personal health care. Today's specialist is Eric Yang. Dr. Yang is currently an associate clinical professor of medicine at the Ronald Reagan University of California, Los Angeles Medical Center. He obtained his undergraduate and medical degrees at the University of Illinois in Chicago. He completed his internal medicine residency and cardiology fellowship at Harbor UCLA Medical Center, where he served as a chief fellow. Since joining the academic facility at UCLA as a clinician educator in 2011, he has both been involved in the invasive and non-invasive realms of the field, serving as one of the cardiology liaisons on the lung transplantation committee. He also serves as a member of the structural heart intervention team. Dr. Yang's clinical interests also include medical education, where he served as the Associate Program Director of the UCLA Cardiovascular Disease Fellowship since 2013. He officially established the UCLA Cardio Oncology Program in 2016, which he continues to lead. Thank you so much, Dr. Yang, for joining us today.
Thank you very much, Lee, for the kind introduction. The privilege is really mine to be here, and I really want to thank you and the AAMDS International Foundation for this invitation to speak about cardiovascular health after bone marrow transplantation. Just to talk a little bit more about my background, I've been on faculty here at UCLA in California, and I hope overall, given what is going on in the country right now, you are all doing well, and your families, and also many of you, I imagine, either are patients or loved ones of patients, are otherwise in good health and safe. Coming from California here, a lot has gone on politically and biologically over here as well in the past week or so. So I imagine this is a very tumultuous time for many of you. So my best wishes for all of you as a whole. So, as part of my role in running the cardio oncology program here, which, if this is an unfamiliar term for you, I will talk about this in my talk, is really focusing on patients who are at multiple stages of their cancer treatment, either before treatments with a new diagnosis, during treatments, and obviously I will focus on bone marrow transplantation, as well as short and long-term effects and things to look out for. And it's going to be, the conversation here is really going to be a mix of some data, which I hope I don't bore you too much with, but also again to emphasize just how critical it is that cardiovascular disease and health in many cases get, altered in the cancer survivor. And what you can do on a personal level, and also to be an advocate for yourself or your loved ones, to your doctor or cardiologist, to make sure your cardiovascular risk factors stay in check, and how you could stay healthy for years to come during and after your treatments. So it's always a privilege. Again, it's always great. And I always am humbled and educated by the patient perspective and family's perspectives as well. So, so here I will begin. Sorry. First, my disclosures. Here are my disclosures as listed, none of which are relevant to the nature and content of this talk. I also would like to give a special thanks to Dr. Saro Arminian across the Los Angeles County geography, who is a big cancer survivorship, pediatrics survivorship guru, much of whose data I will be citing, who also helped with these slides. So the outline of my presentation is, first of all, the current state of cancer and heart disease, not just, the lymphoma, leukemia, bone marrow transplant population, but just to really emphasize really where, the field of cancer as a whole has gone in improving survival, and why now heart disease remains the top cause of death in non-cancer and arguably cancer survivor populations. And for those of you who have not heard that term yet of cardio-oncology, I will have a brief introduction of what this is, what this growing field is, and how this may potentially apply to you or your loved ones long-term, and why it is important to, why cardiac effects are important. And then I will go over short-term and long-term effects of bone marrow transplantation, and how they relate to more classic cardiac disease factors. And finally, well, what are some methods of screening for disease after cancer? And what can you do to stay healthy? So this is a recent curve graphs of overall death rates by site and sex in the United States. These are more solid tumor or solid oncology based numbers, as you can obviously see here. But overall, you could see the trend as a whole since the 1990s have really, decreased over time. And while there's a lot of debate over what has caused this, the one unanimous, consensus is probably the development of treatments. And this also applies to the leukemia, lymphoma, and bone marrow transplant population. Many of you may recall, who are old enough to remember, and I remember this even before I wanted to be a doctor, hearing the news in the 1980s about, leukemia being potentially, a top cause of death in the pediatric population. And now this is no longer so with the bone marrow transplant advances in treatments. And you can see here looking at male and female. Still, as a cardiologist, we unfortunately lay claim to being the top cause of death in adult women and men. We know that in the media, there's a lot of attention focused on breast cancer and other cancers as well, but really ultimately, it still remains cardiovascular disease is the top cause. And if you also focus on ethnic minorities and females, it's still cancer is the #2 cause, but cardiovascular disease, or what I will refer to as CVD, well, it still remains the top cause of death. And as cancer survivors grow, which I will show you in the subsequent slides, overall cardiovascular disease will be the top, will be the major cause of morbidity and mortality. And as before, and as I will show in further slides, as by 2030, we estimate over 22 million cancer survivors will be alive in the United States. 2/3 of adults diagnosed with cancer will be alive in 5 years, and 3/4 of children will be diagnosed with cancer will be alive in 10 years. And many patients will have radiation and/or cancer treatments with the potential to affect the heart and cause premature disease. And I'll talk about that momentarily, what kinds of things that could occur. And the risk of cardiac death in patients with certain regimens is higher than a risk of actually having, your cancer come back. And this applies more to the pediatric population, but compared to siblings who did not have cancer, unfortunately, there is epidemiologic data suggests that, there's a higher rate to pass away earlier, develop other cardiovascular disease states like heart failure, heart disease, and stroke prematurely. So this is where our field comes in. And again, this is really just a testament to our cancer colleagues because, given that 20, 30 years ago, the prognosis for so many cancers was very poor. And really now, it is really now up to us to also take the helm of saying, well, for many cancer patients, surviving it or going to remission or even living with it, it's important to not let your heart care, and cardiovascular care go to the wind. And what my field deals with are three major factors here. One, someone's risk factor profile going into cancer. Now I'm going to allude to some other cancer disease states, but those who are diagnosed with leukemia and lymphoma or breast cancer or colon cancer may frankly still have other risk factors going in, like diabetes, high blood pressure, being older, being a male, right? So we look at those as potential risk factors of patients that might have issues with treatments long-term or even short-term. And then finally, what does the cancer itself do to the body, right? What does it directly or indirectly do? And I will more on that in a moment. And then also the cancer treatments they are getting or about to get, or the cancer survivors who show up in my clinic. What have they received? Radiations or anthracyclines or certain, toxic therapies that could cause issues, and they may not even know, or they may even have a problem. And this very, eccentric Venn diagram shows this intersection. And this is where, our field comes in, is looking at forms and degrees of cardiotoxicity, or, ways that the heart and the vascular structures can be hurt. And if you get toxic acutely during treatments, this obviously can prevent you from getting life-saving treatments you need for your cancer, but also long-term, even if you complete the treatments, it can affect your long-term survival, morbidity, and also quality of life. And I would arguably say the latter two are incredibly important once you've passed your treatments. And I see patients along all spectrums. And given I work at UCLA, which has one of the top bone marrow transplant volumes in the state, physical activity and functionality to me in my limited time has really played an important role of how they overall do. And we have evidence to also back that up as well. And what makes my job so, daunting and exciting is that this Venn diagram with this really lame animation that I try to do shows that the Venn diagram and the intersection changes for every patient and every kind of drug they get. And it remains a multidisciplinary personalized effort. Everyone involved in the care of the patient, if someone has heart issues during treatment, it remains a very ongoing discussion with the cancer doctors, the nurse practitioners, the social workers, importantly, the family and the patients with their goals of care, of how aggressively we can try to manage their heart disease, whether it's acquired or pre-existing, to try to get them through their treatments in order for them to complete that. And it's really rewarding when you can actually carry someone through not just cancer, but heart disease to get them through their treatments and have them be able to live through both issues. So why does cardiotoxicity occur? And this is, a very different explanation for every kind of drug, every kind of cancer, every kind of patient. But a very good overbroad theory of why this happens is just what we call the multiple hit hypothesis. And really that if you go into treatments now, children or kids are less likely to have these issues because in general, they don't tend to have risk factors going into treatments. But long-term effects, it's more on the later end or later tail when they survive and they grow to adulthood, they're more likely to develop cardiovascular risk disease factors and disease much later. But those who are older adults going into treatments, they may have pre-existing risk factors. But then what does the cancer and chemo do to you, right? It makes you weak, it makes you tired, it makes you sick. Medications and that you normally would take for your blood pressure or cholesterol levels, you can't continue because your liver has issues, your kidneys have issues from dehydration. Your cardiovascular reserve, if you were exercising before, you probably aren't doing so much now. And especially with COVID, a lot of people's exercise routines are really altered. So the indirect effects that the cancer treatments can do for you really can be long-term, very, impactful and detrimental, not just the direct effect of the medications themselves. And also, we don't know how, these patients will fare in terms of, on medical medications, because most of our trials looking at heart medications aren't tested in cancer patients. And a lot of us arguing that they should be. And again, looking at this spread of cancer survivors, and especially focusing on the bone marrow transplant related population, by 2030, we anticipate that over 1 million some survivors will be in this country. So it is a huge chunk of the population that we need to watch out for long-term cardiovascular effects and consequences. And just focusing again on the lymphoma, myeloma, leukemia cases of new cases, we continue to have them every day. I see a lot of these patients at all points of the spectrum here at UCLA, and they all have different disease, different varying degrees of severity of cancer disease and cardiac disease. And we have to juggle the risk benefits of continuing such medications and what some of the treatments for the cancer can cause itself, that also we have to be very careful about. But overall, as I alluded to before, 5-year survival rates continue to get much better. You can see here across the spectrum in the earlier eras compared to the 90s and the 70s and the 60s, it's all going up just from better treatments overall. And again, this is then where cardiovascular disease will unfortunately be the cause of further illness and life expectancy being cut short if we don't take care of these patients. And what are some other things that are important to focus on? Well, this talk was mainly focused on bone marrow transplant, but all of you know that the bone marrow transplant process itself was preceded by some other disease process, right? Lymphoma, leukemia. And many of you have undergone treatments, or your loved one has undergone treatments that also could cause long-term effects. And some of you may or may not be aware, but I don't have time to focus on all the different agents, but things that we worry about are historically people, let's say, who've had radiation treatments. And really one of the bigger guilty parties, which are very effective in saving your life from hematologic malignancies, but also can long-term cause signals that can aid your heart function, is the anthracyclines, or in other terms, some of you are probably aware, idarubicin, doxorubicin, adriamycin, as the brand name is, or as a nickname called the Red Devil in some southern parts of the state. That's something I learned a year or two ago. I actually did not know that. These are all effects that we suspect affect metabolism and DNA production in your heart muscle in a certain vulnerable population that can be lifelong. And again, based on what you have, it's not necessarily just the heart or the vessels that we get concerned about. It's also the heart muscle, the rhythm, the conduction system, the valves, especially those of you who receive chest radiation. These are all things that warrant long-term surveillance if you've had any dose or any kind of treatments related to radiation or chemotherapy. And this is why survivorships are very important if you're not actively following with your cancer doctor, to make sure that you are referred if you are at elevated risk. And many patients can have no symptoms for years to decades until they do finally present to us sick. And by that point, it may be very end stage. Looking specifically at, we'll call, hematopoietic cell transplant, you all know the two types: autologous, where you use your own stem cells, or allogeneic, where you use a donor, where the risk of graft versus host disease is a possibility. We know that bone marrow transplants have gone up exponentially over the past couple of decades, but really where what we worry about in terms of where cardiotoxicity can occur, it can be anywhere along the line of that treatment. As I said before, in the pre-treatment phase, if you're a lymphoma leukemia patient, you're probably getting some degree of chemotherapy, including anthracyclines, radiation, depending on the era in which you were treated. And after that, if you need bone marrow transplant, you have induction treatments, you have total body irradiation, and if you go well with it, you still have to watch out for certain things. But those of you who may develop, let's say, graft versus host disease, the medications, the immunosuppression you have to be on, the prednisone, the tacrolimus, all of these things can affect your cholesterol levels. They can affect your blood pressure. They can affect your kidney function, all of which we know are indirectly tied to long-term cardiovascular disease. Now, the next several slides are going to focus on some studies looking at long-term cardiovascular disease and event rates. This is the more quote unquote academic portion of the trial of the slides. And I hope to not bore you with these, but I want to show you as clear cut as I can why many of these disease groups like lymphoma, leukemia, and bone marrow transplant are associated potentially with long-term issues. And there have been data now for the past decade at many centers who have done bone marrow transplantation for a long time now, emphasizing why it's so important to keep track of your cardiovascular health. So the one thing I want you to all take away from this is really ultimately, to think of yourselves as having an additional risk factor like diabetes, and the importance of your diet, exercise, and following up with your primary care doctor and your cancer doctors to make sure you can do everything you can to enhance your heart health. And if necessary, to follow up with someone like myself as a cardio-oncologist. So the first slide I'm going to show here is looking at actually a pediatric population of over 1,000 pediatric groups in the Children's Oncology Group. And these were patients that were treated that had acute myeloid leukemia or AML. And they also showed that in general that if you had an infection or non-infection related, in general, there was still an associated risk of what we call cardiotoxicity, or if your heart functioned, the LVSD stands for left ventricular systolic dysfunction, which I will get into a little bit more so. And that patients in general with these treatments, and if whether you had an infection or not, were all associated with a high association with cardiac dysfunction, which may lead to overall, more cardiac issues with heart failure, heart attacks, and other things. And detection and treatment of these issues is paramount. Now, looking at patients who also developed atrial fibrillation, many of you may be familiar with that term. It's one of the most common arrhythmias in the country, if not the world. The arrhythmia itself is not necessarily a problem, but unfortunately, when your heart beats in a disorganized fashion, that puts you at risk for a stroke. And that also requires very close surveillance and whether you need blood thinners to reduce that risk. And in general, it shows that patients who had bone marrow transplant, here defined as HCT, the cumulative incidence overall was pretty high. And also you could see in this specific cohort here in this study, although it was a small study between 2014 to 2016, out of these patients, about 39 patients developed at a median of 56 days, so 2 months, developed atrial fibrillation. This was an older population, and many received radiation and chemotherapies, and 2/3 had graft versus host disease. But when someone like this has these issues post-bone marrow transplant, I do get very worried about their ability to get these arrhythmias. And many of you may recall that your blood counts also can be very low. You can't get classic medications, including blood thinners. So, but if you had atrial fibrillation, overall survival was considered to be worse overall. So, atrial fibrillation is something that we see more prevalent in the cancer population. If you look at lymphoma patients as well, CVD or cardiovascular disease is unfortunately associated with worse outcomes overall. And if you also look at the incidence of heart failure, again, we attribute this probably indirectly because of what it does with your cardiovascular reserve, the chemotherapy, but also a lot of patients with anthracyclines and radiation can also be affected by this. So, I view lymphoma patients, frankly, especially Hodgkin's lymphoma patients, as a higher risk cohort. And I feel that arguably that any Hodgkin's lymphoma survivor who ever received chemo and or radiation probably should see a cardiologist at some point in time in their life. And again, looking over at lymphoma again, if you look at younger or older populations, there is definitely, an association certainly to be associated with, essentially a shorter lifespan. Again, these graphs are not meant to alarm or scare you, but this is just to show that, and nowadays I would argue that many of us are more aggressive in making sure cancer survivors are getting better heart health care. And we're emphasizing that to cancer patients more so than we were 10, 20 years ago. And this is important to keep in mind that if once you are, in remission or you are doing well, to really find ways to be more healthy. And I will have more tips on that later in the presentation. Okay. Leukemia and lymphoma in the pediatric population, again, the risk of cardiovascular risk factors, hypertension, diabetes, cholesterol issues are much higher, again, in cancer survivors versus those who do not have cancer. If you look at multiple myeloma and non-Hodgkin's lymphoma as well, across the board, all these issues are higher compared to, people of the same age without cancer. And also long-term bone marrow transplant survivors. Again, it is fantastic now how bone marrow transplant, treatments have evolved to the point now where people can do well from a cancer standpoint. But again, it behooves us to also now focus immediately, if not during, on someone's cardiovascular health. Some of you may remember that when you were in the hospital for your bone marrow transplant, what were you doing for 3 to 4 weeks? You were in the hospital, right? Trying to get better, trying to fight infections, trying to get over your side effects. What can we do to lower these increased risks of the solid line here, demonstrative of cardiovascular death, heart failure, ischemic heart disease, stroke? There interestingly is now a focus on maybe looking at cardiac rehab in patients of bone marrow transplant. Insurance notwithstanding, that's a big problem, a big barrier. Something I wonder about is, well, why can't we get patients who are able to try to put them through exercise regimens during their bone marrow transplant hospitalization, if they're able to do it? Not everyone can, but it's still important to try to keep people functional. And at UCLA, they encourage patients to do laps around our bone marrow transplant unit now. And the thing is, however, is that, people are very different in terms of how sick they are and what are ways we can keep functionality up. And the same thing going back to heart function again. Many of you are used to getting echoes. Many of you have gotten cardiac imaging as part of your workup or before and after you got chemotherapy. But we know that patients who have been treated with allogenic bone marrow transplant, especially that risk factors of age, graft versus host disease, having hypertension, or if you had a high anthracycline dose, which you can also get from your hematologist, can also impact your long-term effects on your heart function. And in this cohort looked at, that was published just last year, I believe it was a European cohort. They looked at 104 patients, over half of which were women. Almost half patients had evidence of what we saw cardiac dysfunction, where the heart wasn't pumping as well. And again, what does this mean for the patients? Well, we don't exactly know, but in all other populations, that can still mean potentially more comorbidity. And these are patients we frankly want to manage very aggressively, not with just lifestyle modifications, but with heart medications that can potentially reverse this or keep it stable. And then going back to the bone marrow transplantation, again, you can see here across, another, big in Washington, looking at, bone marrow transplant populations compared to normal controls, just a higher risk long-term years of high blood pressure, kidney issues, cholesterol issues, and diabetes. So Dr. Armenian also wanted to try to do a better systematic way of, well, how do we assess people at increased risk of heart issues? And, they looked at evidence of which kind of risk factors put you at increased risk of heart failure, as well as potential issues of heart failure, stroke, and myocardial infarction. And they found out that if you had evidence of 2 or more risk factors, and this can include, hypertension, diabetes, cholesterol issues, you were at increased risk. And I think these are people, in my opinion, cancer survivors that should be flagged. And as good as your cancer doctors are, they're not necessarily trained to necessarily focus on these issues, and this is where I say, as the patient yourself, or being the family member of a patient, to really kind of focus on some of these risk factors that may develop over time. And if need be, to be referred more aggressively to a survivorship, primary care, or a cardiologist who is sensitive to these issues and can help manage these cholesterol and blood pressure issues, both through lifestyle modifications and medications if necessary. And another study that he did as well was trying to come up with a risk score. And they found out that, these are some, risk factors that people looked at. If you were older when you were treated, if you had a high anthracycline dose, you have hypertension, diabetes, smoking, if you ever had chest radiation before, during bone marrow transplantation. And they found out that a high risk, if you scored 6 or above, your event rate was actually quite high. So again, this is not necessarily death, but this is any kind of issue of heart dysfunction, rhythm issues, diagnosis of heart disease, things like that. So heart disease, like cancer, has become a chronic disease process for many people, and we can keep things under control with good medication use, adherence, and dietary and lifestyle modifications. So all these numbers may seem like a whole, tidal wave of numbers here, but the graphs, I hope, demonstrate to you all that basically risk factors for classic heart disease and risk factors go way up in the cancer population. And it's really important to kind of focus and stay focused on these once your cancer issues have stabilized. So, how do we go about doing this? And how do I go about doing this? Well, first of all, I personally think, because as I just alluded to, cardiovascular disease is the #1 cause of death in adult men and women. it goes without saying that anybody, whether you're cancer or not, screening for cardiovascular disease is important, but it's critical in patients, especially who have received the kind of therapies that you've had for lymphoma, leukemia, and bone marrow transplant. If you are not actively following with a hematologist, I do highly recommend, if possible, in your area to look for a cancer survivorship. I'm very fortunate at UCLA that we have the Live Strong Cancer Survivorship here. They actually are the ones who got me into this field by pure chance. But they do a lot of things. As a heart doctor, I only look at one part of the body, and I know, frankly, very little about a lot of other places in the body. And, there's a lot of other things, like reproductive health, endocrinologic health, also what to look out for in terms of secondary cancer screening, psychosocial, psychological impact and counseling. That is a huge issue, as many of you know, and also for family as well. And also many of them have the resources, if you were treated somewhere 20, 30 years ago, to also try to get records, or based on your history, they can kind of get a sense of what you may have received during your treatments if you don't remember, and then kind of give us guidance on what to look out for. And again, as many of us all believe, primary prevention is better than secondary prevention. So for those of you unfamiliar with these terms, primary prevention is basically using interventions to prevent a disease from happening, like a heart attack or heart failure. Secondary prevention is the heart failure or heart attack has already occurred, and we want to make sure that that you don't have it again. And ultimately, our goal, including my own as part of the cardio-oncology program here, is identifying cancer survivors before they get problems, especially those at risk. So what are some technologies we have now? Some of which you may be familiar with, some of you that may be new to you. So I imagine that most of you have already had one of these before. It's an echocardiogram. And the top one is one of our classic, what we call surface echoes or transthoracic echoes. Many of them who received adriamycin and anthracyclines probably had to get one of these before your treatments to make sure anything was okay. It defines what's called your quote unquote ejection fraction, especially for left ventricle. Some people call it your squeeze. This is really, really the most, low cost, high effective, no radiation based treatments. And if we need to, if you're wondering what this fancy picture is down here, this is a 3D image of someone's mitral valve with mitral valve prolapse, which we can use for more invasive techniques that can get better embolization for valves. So those who have received chest radiation where valve disease can be occurred, we actually use this quite frequently for, for severe valve disease in case they needed something operated on or replaced or repaired. But this is really what we use now, and technology has really gotten better where we can get 2D and 3D images now. So you may be asking yourself, well, should I get an echo? My basic answer to you is directly in the audience. I don't know your personal history, but maybe something you should ask your doctor about whether you should get one at some point is if you have ever received, let's say, anthracyclines like doxorubicin, adriamycin. Many patients with lymphoma leukemia probably got some dose or some exposure to it at some point. This is more for the breast cancer population, for anti-HER2. But chest radiation, bone marrow transplants, I do serial echoes depending on how much chemo they received beforehand, anywhere from 1 to 5 years. If their heart function ever deteriorated on treatments, I tend to check them every 1 to 2 years if they have no symptoms. If you're currently on treatment with, let's say, tyrosine kinase inhibitors, again, this is more for the broad audience, or immunotherapy. I know some people are on experimental therapies now. Immunotherapy is now being tested in a variety of populations, including lymphoma, leukemia. And also, if your doctor is not sure, if your cancer doctor, it may or may not be sure, cardio-oncology centers are warranted. Now, for those of you who are across the country, in the Q&A section, if you feel that you would like to see someone, I have a lot of colleagues in multiple cities. I can also do my best to provide some live internet searches to let you know who we can recommend depending on where you live. So I can try to help with that as well. Nuclear cardiac imaging. Many of you may have undergone what's called MUGAs, that's really sort of the older scan looking at LV ejection fraction. There's also stress testing and PET testing. PET, many of you may be familiar with this for staging of cancers, but we also use it for heart disease to look for evidence of blockages in the heart or inflammation. So, these are some other things we use long-term to look for heart disease. I personally prefer echoes over MUGAs now because it gives you a lot more information. Without the radiation, and MUGAs are more of an older technology, but depending on the resources your doctors have, I know it is still used in clinical practice. CT is something I have a personal, predilection for, and we are actually, doing research and publishing on its potential uses. But really, coronary calcium is really a direct validated marker of cardiovascular risk. And it just basically looks directly at plaque, as you can see here in this picture here, looking at, the heart vessels. And for someone that doesn't have symptoms, it helps me redefine someone's individual risk. We don't know how cancer, or the treatments have an individual impact yet. We don't have that kind of granular data. So in the meantime, I do this to help define whether someone needs further workup of their heart dysfunction, chest pain, or they need statins or cholesterol medications or aspirin to be more aggressive with lowering the risk of heart attacks. Because the higher your calcium score is, the more likely you're going to have, potentially a heart event. And we don't know what the effects of radiation and chemotherapy will do for each of these, for everybody. And cardiac MRI is also really, you can see these beautiful images here of a cancer patient with pericardial disease. It's really just beautiful images looking at heart structure. We also use this as well. There's no radiation. It can also look at signs of inflammation in the heart, scar, and also there's a lot of interest in ongoing use of looking at signs of early cardiac toxicity as well. So, and I use this not infrequently in my practice. Angiograms, many of you may be familiar or have had loved ones who've had heart attacks or heart disease, and this is really the gold standard of looking at, blockages in the heart. People who've had certain high-risk treatments like chest radiation, we get concerned about high-risk disease, but we really only perform it on people nowadays with heart attacks, chest pain. CT technology is a good non-invasive alternative for certain selected people, but we can also use it to assess the severity of valve disease or heart failure. It gives us a lot of good invasive data as well. So what are things that you should watch out for? If you have evidence, if you have evidence of signs of cardiotoxicity, meaning heart dysfunction, heart disease, these are some symptoms as a guide. This is not, not necessarily the only symptoms, but some main things I warn patients about are just generalized fatigue, or if you just get more winded walking around, any kind of unusual chest discomfort, abdominal discomfort when you walk. We know women also have more atypical symptoms of heart disease as well. If you have difficulty breathing while sleeping, you need to pile more pillows on to sleep. Just a lot of persistent cough, especially when you lay down. You feel fluid in your belly, or just palpitations, lightheaded, fainting. These are all things that usually warrant a cardiac workup, just to be on the safe side of things. Now, going over to you, on top of seeing doctors and being on top of your health, well, what can you do to stay healthy, right? So to the general population, something we have done in the past, within the past decade, is reassess, cardiovascular risk. Until recently, a lot of the models we use to gauge someone's heart attack risk were based off of, basically older white men. And we know that, people in other ethnic minorities, females, things like that, the cardiovascular risk was not as well defined, and we did not know if it was truly accurate. So this is a risk calculator that any physician or healthcare professional can use to look at, one's risk factor. And really, this is something that's frankly kind of our fault. We've kind of miseducated the public about how important LDL is. It's just one piece of the pie of your risk assessment, or the bad cholesterol assessment. A cholesterol level alone is not a crystal ball into your heart health. I wish it was. If it was, you wouldn't need us. In fact, most heart attack patients have pretty good cholesterol levels in the LDLs of 110s to 120s. And this is a cohort equation calculating one's 10-year risk, either of having a heart attack, stroke, or dying of such, for 40 to 75 years of age, and includes a variety of endpoints. And if it's above 7.5%, on top of lifestyle modifications, it's important to maybe consider, statin use as well. And again, we are not pill poppers as doctors. We still, feel very strongly, ultimately, the most important thing you can do for your health is, a good, a strong diet, and I'll go over that momentarily, and exercise and lifestyle modifications. However, the one limitation of this, again, related to this talk, is that we don't know where cancer, plays into your risk factor profile. And I would argue, say that for many patients, it elevates your risk so far more, and that's a topic of discussion. So in 2020, and you can access this is free for reading, the American Cancer Society published their second iteration of guidelines of diet and physical activity for cancer prevention. And their number one recommendation, just like we do, is say achieve and maintain a healthy body weight throughout life if possible. And this is also to prevent the recurrence or the onset of cancer as well. And what can you do to be physically active? Well, obviously, it goes without saying being physically active, and we know, especially with COVID, it's more difficult to get out there and walk or go to your local YMCA or swim. And understandably, many cancer survivors do not want to be necessarily around other people for concern of infection, whether even if you're vaccinated or not. And adults should engage, in 150, 300 minutes a week of moderate intensity, which we'll talk about momentarily, or vigorous intensity, less so. And I tell patients in general, and I ask them all the time, I say, well, what do you do for exercise? And they go, well, I walk for an hour, and I say, okay, well, are you breaking a sweat? And you'd be surprised at the answers. Many people just say, oh no, I walk a mile, it takes me like 40 minutes, I don't break a sweat. That probably means you're not pushing yourself, and really, in order to burn fat, I tell people you need to build, at least break a mild sweat to really show you're doing something, you have a net negative impact, if you will, on fat burning, calorie burning as well. So, and the same thing for children and adolescents as well, to engage in at least 1 hour of moderate or vigorous activity. And then, the American College of Sports Medicine also have very similar, I apologize. They have similar recommendations as well. And again, as many people say, some activity is better than none. So even if it's hard to kind of take that walk outside the block, it's certainly better than doing nothing for the rest of the day. And what are some examples of moderate and vigorous activities? Here are some examples here, and they're actually a lot more commonplace than you think. Moderate activities in general, I would say that something that a lot of people like to do is gardening. And the good news is you're isolating your home. And if you like to do that, raking, trimming shrubs, keep yourself hydrated if you're in an area of hot weather. For people that unfortunately may have, functional issues with their lower extremities, knees, using your manual wheelchair is also important. Swimming is great. I tell patients with knee issues, that's a great option, but I also know that unfortunately with COVID, that has been rather limited. And vigorous activities is where, if you were trying to talk while you're exercising, you can only say a couple words without, stopping to catch your breath. And here are some examples of that. The most researched population is actually breast cancer. And their goal is to really to curb your weight gain, but also keeping your muscle mass. And really moderate physical activity, especially resistance training, can help maintain lean muscle mass while avoiding excess body fat. And again, many patients who are on bone marrow transplant, you are on steroids, you are on tacrolimus, you're on other medications that unfortunately will affect your body fat distribution and your cholesterol levels. But overall, they said that a meta-analysis, just looking at over 12,000 cancer survivors, show that post-diet physical activity can be associated with a lower cause mortality. Now, in your population, especially a childhood Hodgkin's lymphoma, we know that actually this is based off questionnaire, that people who survived, their lymphoma, and they called these people and said, well, what kind of exercise are you doing? How much are you doing a week? And we measure these by METs. And the median follow-up here was over a decade, about 12 years or so. And essentially it showed that if you were able to do more than 9 MET hours per week, it was associated, compared to the people who could not, it was associated with a 50%, increase in cardiovascular event rates if you could not do 9 MET hours per week. And that's also, again, if you're able to adhere to the National Vigorous Intensity Guidelines, like which I just presented to you, in general, this is long-term better. And also this actually applies to breast cancer survivors as well. So this is why I tell patients, it's hard for me to relate, obviously, because I'm not going through the same thing, but to really try to maintain as much normalcy as you can during your treatments. Healthy eating pattern all ages and no matter what phase, right? And again, these are some very nice kind of things and illustrations to kind of go over foods that are high in nutrients and amounts that help achieve and maintain a healthy body weight, a variety of vegetables. Again, think green fruits if you're not diabetic, whole grains. Really try to avoid red and processed meats, beverages, even diet soda in general, I tell people to stay away from, and highly processed foods and refined grain products. Again, the Institution of Medicine federal guidelines and the American Heart Association also state too, this is kind of how you want to distribute your sort of fat, carbohydrate, protein makeup, okay? Alcohol, right? Well, we know that's probably all gone up to a certain degree during COVID, but in general for cancer survivors as well, it is best not to drink alcohol. I also tell patients, even a glass of wine a day, if you're not exercising, it's a really big source of carbs. They really say limit your consumption to no more than 1 drink per day for women and 2 drinks per day for men. And finally, another kind of nice algorithm to think about, again, for physicians and for patients, is the ABCDE steps, kind of that was sort of pushed by one of our cardio-oncology gurus, Dr. Javed Moslehi at Vanderbilt, who is now going to UC San Francisco. Again, A, awareness of patients who may have symptoms of cardiovascular disease. If you already have known heart disease, aspirin is important, or in certain selected populations, 81 milligrams can be helpful. The blood pressure now, our new cutoff is now 130 over 80, actually. This was advertised before the new guidelines came out a couple of years ago. Cholesterol, again, diet, lifestyle modifications, but if you already have known heart disease, you really should be on aggressive statin therapy to lower your LDL and, all the associated benefits with that. If you're a smoker, obviously try to stop. If you have D for diabetes mellitus and diet, again, we've already gone over that. Very good rigid blood pressure control and avoidance of excessive alcohol, and exercise with the recommendations that we just discussed. And again, although I don't have time to go through all this, coronary artery disease, if you already do have it, aspirin, statin, beta blockers, many of you may be familiar with some of these medications, angiotensin converting enzyme inhibitors like lisinopril, benazepril. Fish oil has questionable benefit, but I tell patients I'd rather you, if you can afford it, to eat fatty fish, but this is also a good supplement. And also, if you do have cardiomyopathy or heart dysfunction, beta blockers, ACE inhibitors, we don't have time to go over all the details, but aldosterone antagonists, diuretics, all have, mortality benefit and can also potentially improve one's heart function. And our goal is to catch it early in patients who may have heart damage from certain treatments. And again, tight control in blood pressure and diabetes is really important. So we're wrapping up here at the end, and I thank you for your attention, but really in conclusions is still cardiovascular disease remains the top cause of death in adults in the US despite advancements in risk assessment and treatment. Late cardiovascular effects can develop and should be closely watched. And I would say the patients who are higher risk are those who've had anthracyclines and radiation exposure. And diet and lifestyle modifications are paramount, again, to improving quality of life and decrease the risk of having heart events or dying from such, and arguably even in some cases having recurrent cancer, and following the ABCDE algorithm. And cancer survivorships provide invaluable resources and also referrals to us if there's a heart concern, and awareness of long-term effects of cancer treatments, and also give you access to a variety of subspecialists. And from a heart standpoint, we continue to have development of new cardiac imaging and treatment technologies that will hopefully detect disease earlier and treat established disease more effectively in cancer survivors, because we ultimately want you to live a good life after your cancer treatments, and we would frankly hate for you to be felled or have your life irrevocably affected by heart disease that was not identified or treated well. And here are some additional resources. I apologize for the light blue background. It wouldn't change, the hyperlinks were all like hard to see, but here are also some resources you can also go to. And finally, I want to thank my cardiology colleagues. UCLA Health is one of the biggest healthcare centers on the Southern California coast, and one person can't do it alone. This required years and years of grassroots efforts with my cancer colleagues to provide a service that has been very meaningful, in my opinion, and very rewarding on both sides of the aisle, both for myself and my cancer colleagues, and also our trainees and our cardiovascular fellows who have an interest in the field to provide immediate, timely care for patients before, during, and after cancer treatment. I believe I'll stop right here. And again, I thank you all for your attention, and I welcome any feedback on how to make this presentation more high yield for your audience. And again, I'm very appreciative and thankful for the opportunity.
Thank you, Dr. Yang, for the wonderful and very thorough presentation. We have a few questions. Our first question comes from a patient who has had an AV node ablation and a pacemaker installed. They'd like to know, can they still have a stem cell transplant?
So, that is that is a very good but complicated question because that is dependent on several factors. One, it depends on the comfort level of your bone marrow transplant program. At UCLA, we have a very high volume, so we tend to take higher risk cases or patients with pre-existing heart disease. That alone by itself should not be an issue. But other things that can go with it can be associated with higher risk, like if you have heart dysfunction. The other things that your doctors are probably aware of is the risk of, when you get your induction and your bone marrow transplants, that can really affect your immune system and make you more prone to infections. So, that is obviously something that will require discussion with your cardiologist, your pacemaker doctor, and the hematologist about the timing and when the best time is to, all things considered with your cancer. So that by itself is not, for us, a contraindication or a way that that bars you from bone marrow transplantation, but it does make the approach a little bit more nuanced and requires, discussion. But that by itself, to my mind, is not a no. So. I can read the next questions, Lee, I guess. How do these treatments impact the diastolic function of the heart? Well, so that's a good question. So for those of you not familiar, so diastolic function is basically, the ability, to try to put it in like a straightforward term, it's the stiffness or the filling pressures of the heart. So diastole refers to when the heart is filling, the lower chambers of the heart. Diastolic function is properties of how the heart is stiff and filling. And the basic answer, and I kind of alluded to this, is that yes, the answer is many of these chemotherapy agents and radiation can affect the diastolic function of this heart. The squeeze by itself or the LV ejection fraction does not necessarily have to be abnormal for someone to have heart issues, which is why it's important that if you have symptoms of heart dysfunction to seek attention, because there are other ways to diagnose diastolic dysfunction with blood tests, physical exam, and certain medications like diuretics, water pills can be needed, or blood pressure control may be indicated to help relieve your symptoms. And this is another thing that I do see in long-term survivors, that this can be impacted, and some people can feel it, some people don't. So the basic answer is they can affect it. I tell patients that, chemoradiation, to a certain degree, it ages the heart faster, and you might have a biologically older heart as a result, and you have to watch for, closely how your heart is doing, through the years if you've had certain types of, anthracycline doses and radiation. Is there a diagnosis where tomography is covered by insurance? So this is a good question too. So I assume you are alluding to computed tomography or CT, which I was kind of briefly alluding to, and I'll move back to the slides here. So cardiac CT, which is what uses dye, it's a non-invasive angiogram. That has a narrow indication. Insurance usually will not approve it unless you have symptoms or you've had stress testing, which is either equivocal or meaning unclear, or you still have symptoms. Calcium scoring does not include dye. It just looks at plaque, and you can see in this lower left-hand corner that's what it looks like. Only Medicare reimburses that first line. So depending, at UCLA, out of pocket is $240 to do, and I offer this to patients if they wish to know more for their risk. And it does help me kind of be a little bit more personalized in their approach. In the whole scheme of things, it's not necessarily mandatory to do this, but it does allow me to get more information about their heart health. And unfortunately, at this point for calcium scoring, only Medicare covers, if you're primary Medicare, it covers it up front. But most other like Blue Shield, Anthem does not cover the calcium scoring. But CT can if you have symptoms. Next question is, I'm considering stem cell transplant. Is having a single stem for 77% blockage and going ahead. That is something I cannot directly answer in your situation because, again, it's related to the pacemaker question. It really depends on the comfort level of your bone marrow transplant program. It also depends on when you had the stent placed and how your numbers look. We've had patients with coronary disease go for bone marrow transplant who've had stents placed. But again, it really just depends on the activity of your blood cancer and the timing and what blood thinners you need to be on from that standpoint. And that obviously requires cardiac input. How much does family history affect your CV risk versus high cholesterol? That's a very good question. If you do have a strong family history where you have family members who have had, heart attacks at young ages, usually below the 50s, that is something you need to watch out for. Sometimes high cholesterol is tied with that, and sometimes it is not. And this is why it's important to keep following with a primary care, physician. I have noticed, again, I don't have any widespread data, but people who had bad cholesterol going in to bone marrow transplant have worse cholesterol because a lot of them don't stay under statins, things like that. But I would say that does pose additional risk long-term. So it's very important for you to, reassess your heart health once you are through with your treatments. A lot of the bone marrow transplant doctors do not check cholesterol levels. In fact, that is something I add to their blood work. And I remind patients to make sure they check, to make sure that they don't need to be on cholesterol agents. But at least at UCLA, it's gotten to a point now where the nurse practitioners do a great job in saying, hey, Eric, hey, this patient's cholesterol levels are pretty bad. Can I start this? And I'm like, absolutely. So it's a bidirectional, street of learning. And our goal is long-term to really avoid, having them have heart events long-term. And statins, the public knows them to be kind of cholesterol lowering agents, but that's only one thing they do. They lower inflammation, they stabilize plaque, they also decrease the risk of, plaque rupture, which is what causes heart attacks. So, again, this is not things that I expect, patients to know, and you already have a lot on your plate with worrying about your cancer and worrying about side effects and chemotherapy and toxicity, but these are things that we want cancer doctors to be to also contribute and help long term. Because again, in my opinion, for many cancers, this is not the era anymore where people can just go to you and say, well, you have leukemia, lymphoma, your bone marrow transplant. Don't worry about anything else. Eat whatever you want. Don't exercise. Just take care of yourself. I would argue that if your prognosis overall is good, and that's obviously a big, delicate term, it's important to try to, maintain as much normalcy in your daily routine and physical activity. And people are actually actively researching that now, to look at the effects of exercise during treatments. So we know that I think it's a very simplistic, but potentially very impactful question to answer and understand. And I'm in the camp that feels that people should be as physically active as possible, during the treatments if they can tolerate it. So.
Thank you, Dr. Yang. We have one more question.
Mhm.
Most bone marrow failure patients undergo blood transfusions,
Mhm.
whether they're in the midst of diagnosis or
Sure.
when they're starting treatments, and that can sometimes lead to iron overload.
Sure.
Does the number of transfusions and iron overload impact having cardiac issues post-transplant?
That is a very
What's
good
the
question.
effect?
That is a very good question. And the thing is, unfortunately, I don't know the answer to that. I think that, none of us have a ballpark that, if you've had 10 transfusions, you're at risk. It's a mix of how they look, how they feel, how their heart looks on echo and other screening. Very isolated, very few transfusions is not enough to get heart failure. But for those people with, let's say, aplastic anemia, MDS, who have required transfusions like every week or so, those are people who have been on it for months to years. Those are people I do get concerned about being at high risk. I personally don't know if there's a cutoff of when one is high risk, but the people who tend to be transfusion dependent are the ones I watch out for. The ones who needed it every so often, like a few times during treatments, that's of minimal concern.
Thank you so much, Dr. Yang, for sharing your time and your expertise with all of us today. And if you'd like to watch this webinar again at a later time, it will be available on our website within 2 to 3 business days. If you have any additional questions, please send it to us at any time in 3 ways. Send an email to help@aamds.org, call our helpline at 800-747-2820, extension 2, or submit your question to our Facebook page. On behalf of the Aplastic Anemia and MDS International Foundation, thank you for joining us today and making us your resource of choice for information on bone marrow failure diseases. Our medical advisory board and team are always here to support you and your family, as we've done for the past 37 years. This concludes our program. Thank you so much, Dr. Yang. Have a great day.
Thank you so much. It was a pleasure and privilege. Thank you for having me.